So there is data showing that for every missed intubation attempt, you're increasing the risk of mortality and morbidity for the patient in a non-linear fashion. So it's actually an exponential increase in risk for that patient.
That was a brief segment from our episode talking about Jakob's airway management thesis that he's doing for his master's. We broke this podcast up into 2 segments. In this first episode, we prepared to learn how we can optimize first pass success rates of intubation in the pre-hospital setting, how direct laryngoscopy compares to video laryngoscopy, and overall, what are the detrimental consequences if we try subsequent intubation attempts. Describe that this podcast is separate from our professional roles and responsibilities. This is the 10-8 Show. Hope you enjoy.
Give us a brief overview of your master thesis right now.
Yeah, so right now I'm looking at comparing the first pass success rate and like overall success rate of direct laryngoscopy compared to video laryngoscopy. So just trying to see if this is kind of an intervention that we can use in the system to improve the quality of care for intubation by ACPs.
What got you interested in that? Why was that your master thesis?
Yeah. So I've always been interested in like advancing airway management for paramedics, especially in Ontario with our kind of like atypical skill set, especially when you compare it to other countries and other systems, right? Like we're practicing endotracheal intubation, but we don't have RSI. So we're kind of this unicorn a little bit. And I think we have a lot more to offer to our patients by providing really high quality airway management, increasing that like baseline first pass success rate and the quality of care of intubation is a good step forward to potentially increasing scope of practice when it comes to that in the future. So it's kind of my outlook long term.
I want to commend you on this because this is such an important topic in paramedicine because we all know paramedics right now don't have a very good first pass success rate. And again, that's multiple system levels, which we're going to look under the hood about during this podcast. But I really do want to commend you on that because that's a huge undertaking and you're just trying to improve the whole profession. And I love that you're really focusing on this because this is truly what we need. So thank you for doing this. And just looking at your journey, when did this all start? Like when did this like first kind of initiate its first steps?
So I was trying to find like a niche that I could work within in the field of like advancing paramedicine. And when I was just working in Linux and Addington, we kind of did a quick overview of KPIs, I guess is what you call them. So key performance indexes. We're looking at, what is our first pass success and overall success compared to kind of the standard average in the literature. And we found that it was significantly lower than it should be. And that it was extrapolated for kind of the entire profession in Ontario right now. We're roughly around the 60-70% first pass success kind of range. And like I thought, there's a lot of room to improve there if we're in order for us to kind of use this skill more often on a wider range of patients and improve kind of the scope of practice in terms of that skill. So a couple of my projects were focused on like pediatric airway management, especially in cardiac arrest, comparing like ETI to other techniques like SGA and things like that. And then there's still like heterogeneity in the system right now. Like some services have VL and some don't. Obviously, it's a very expensive kind of intervention to put into the system. So I wanted to see if it's something that's worth trying for services right now at cost. And how it kind of fits into an overall model of improving the quality of care for airway.
What are some common challenges that paramedics face when trying to intubate in the pre-hospital setting?
Yeah, absolutely. So there's so many different variables that we have to contend with when we're practicing as ACPs on the road right now. So there's obviously the uncontrolled environment. That's something that we always say with paramedicine. It's like, uncontrolled environment. And it kind of describes just a ton of different complexities that we have to deal with. Like the fact that we have unprepared patients that are always or critically ill, especially in this case, right? That are, not fasted or anything like that. So we almost always have like difficult kind of ergonomic positions. It's more difficult for us to position the patient, most likely have like soiled airways. They're always critically ill. And it's obviously, it's quite task saturated as an environment, right? So Like if you're in a CPN cardiac arrest, you have to deal with, rhythm interpretation, drugs, and airway all together at the same time while trying to maintain big picture. So I think those are kind of a unique suite of challenges that we face as paramedics.
I love that you said that, and, like, about the human factors and everything and the cognitive load that takes on someone.
Mhm.
Because, of course, in the ideal circumstances in the in-hospital setting, you could have multiple people. You have respiratory therapists, emerge doc, nurses, and everything. So everyone has their specific task. But if you're one ACP, the critical patient that needs a definitive airway strategy, you also have to think about drugs, optimal airway positioning. You can see how you just get task saturated, as you said, then that could affect your performance. What can we do to mitigate that and optimize our first pass success rate?
Yeah, absolutely. So, we kind of talked about the things that we can't change in the system right now. We're going to be dealing with critically ill patients. We're going to have uncontrolled environments, and we're probably going to be quite task saturated, no matter what we do. However, there's a lot of things that we can do to prepare for those events ahead of time, and there's a lot of things the system can do to improve the chances of first pass success and kind of quality of care there. So one of the biggest things is education and training and consistent practice. So like maintaining that muscle memory, maintaining those skills is really crucial for this. So in services where it's available, having like mannequins around so that paramedics can train on mannequins like more often, having a wide variety of them so it's not always the same. And then also just when you're doing that practice on your own or with your partner, um, making it more realistic if you can, like giving yourself some time pressure, putting the mannequin on the ground instead of a table, things like that can just make a big difference. Also just practicing with your partner. So if you're lucky enough to have like a full-time PCP partner, making sure that they understand kind of your standardized intubation approach, what you prefer to do for the skill. That way they can anticipate and kind of assist with that. So those are things we can do kind of as individuals, as practitioners. And on the systems level, there's obviously, things in terms of equipment that can be changed. So like having bougies, making sure that the bougies are the right one that your staff is comfortable using and that they're accessible and in good condition when they're in bags and stuff. And then obviously, laryngoscopes, there's a bunch of different ones there. Getting the one that your staff seems to approve of the most, or potentially video laryngoscopes. Yeah.
There's so much good wisdom to unpack there. So if we look at training, I love that you said that, yeah, we should have a variety of mannequins and different like stressors involved. Because if we look at the traditional model, here's an anatomically correct mannequin with no pressure and good lighting. That's not reproducible with the usual environment we work in. So I love that. And just the fact that you said bougies, like why is a bougie so important? And does it improve first pass success rate in the pre-hospital setting?
Yeah. So most of the evidence that we have informing us on this shows that bougies do improve first pass success rate for paramedics in the pre-hospital setting. There's a really good study done by Latimer in 2021, kind of looking into that. And what's really significant about that is they showed that the difference in first pass success was more significant with the worse kind of airway grades. So your Cormichael Hain grade 1, it didn't really make that much of a difference, right? Because anyone can sink a tube on a grade 1. But then it started, the separation existed more in like the poor to grade 2s and 3s. And the thing is, you don't know what kind of view you're going to get until you perform laryngoscopy. So if you go in with your laryngoscope and you have a bougie ready, okay, cool. It's a grade 2, it's grade 3, perfect, pass the 2. Whereas if you don't have your bougie, it's in your bag, it's not your first pass kind of modality, then you perform laryngoscopy, you go to grade 3 and you only have your tube in your hand, you're not going to be able to pass it that time. So you're going to have to do a second attempt with your bougie, right? So that's why I recommend using it on the first attempt. It's going to spare you and spare the patient hypoxia, hypercarbia, everything else.
So it's recommended just get all your equipment set up, have your bougie in place. So when you go in and visualize, it's a grade 3. It's like, well, that's perfect because I have my bougie here. And to operationalize that, where do paramedics actually should landmark to try to get that bougie in correctly?
Really, one of the easiest things to do is if you have like a grade 3, you can pass it like below the, like epiglottis is like maybe going to be obscuring your view. Sometimes you can just follow the blade in as well. So we like train to put the tip of the bougie on the blade and then just follow the blade down. It's especially important with VL because your view can be a little bit different. Yeah. What are your thoughts on that?
That's exactly what I was thinking because I remember multiple docs said this. Like, let's say like the epiglottis is flopping down and you have the best positioning of the patient. There's a try to lift up the epiglottis with the bougie. Then if you just follow the blade of your laryngoscope, that will naturally go in. And I know there's a lot of inconsistency about feeling the tracheal rings. Anecdotally, I felt it a handful of times, but I also like the when it locks up because if you're in the stomach, it should keep going. But if you are in the trachea, it should hit the carina and you get that lock up. So that's exactly what I was thinking. But if we look at video laryngoscope, how
Mhm.
does that compare to first pass success rate in comparison to just standard intubation in the pre-hospital setting?
Yeah. So one thing that's really interesting with, if you just look at pre-hospital care in general, the bulk of the studies do show that there's a trend towards an improvement in first pass success with VL. However, what's really neat is when you kind of isolate the paramedic only ones and then the non-specialist paramedics, like paramedics that don't provide RSI and things like that, the effect size increases quite significantly. So if you were to only look at like paramedics with a scope of practice comparable to ours in Ontario, that's where the biggest impact actually is from VL. So like our non-expert players.
Does burp have anything to do with optimizing first pass success rate for video or direct laryngoscopy?
I think like it's a tool to use depending on the view that you're getting at the time. Like that's why we do teach like partner intubations, that if you do need some burp, you can get it in those cases. It's not like something you always want to do because it can also worsen some views, right? Yeah. So I think it's definitely another tool to add to the suite there, a skill to have with your partner for sure.
I'm thinking about my evolution in intubating because, of course, I wasn't good at it. I don't know if any pre-hospital providers can say it because we don't get enough practice in it. But once I pivoted and said, I always have a partner and saying, this is what I'm going to do. I want you to stand right here and assist me with my equipment. So that I need to apply burp. This is how I want you to do and everything. And anecdotally, my first pass success rate went up because can you imagine doing all those procedures by yourself with no assistance? Like that's extremely cumbersome.
Absolutely. So like taking the extra 30 seconds to make a game plan with your partner and make sure that all your equipment's like, at hand is probably one of the biggest things we can do to improve first pass success. It's not going to be like a device that comes in and magically brings us to like that 80 or 90% first pass success, right? It's going to have to be a holistic kind of strategy to improve.
The Swiss cheese model, basically, we have multiple different factors trying to improve this first pass success rate.
Absolutely.
I know the argument though for video laryngoscope is the cost.
Yeah.
And I honestly am not aware of any data. Maybe you're aware, or this would be a good study. Like if we chose to do video laryngoscopes, would that save money in the long term by less equipment being used if you missed the first time? Would that improve health outcomes if you're more likely to hit it? What do you think with that?
Yeah, that becomes really difficult to prove. It's kind of like showing that one airway strategy over another, especially when it comes to ETI, would have like an impact on mortality, right? Like it's just such a small piece of that patient's kind of journey that it'd be hard to discern whether it was the video laryngoscope or the direct laryngoscope that led to kind of like, decreased mortality, decreased ICU length of stay. And that becomes really difficult to kind of parse out. However, when it comes to the cost discussion, I think for most services, like medium-sized services, getting a VL per ACP would probably cost roughly the same as getting like one more Zoll monitor or one more LifePak monitor. So when you put it into perspective with how expensive kind of all of our equipment is, it's not that big of a percentage.
I want to be respectful and mindful of like services budgets and everything, because of course we have to be financially conservative with it. But if we just looked at the patient safety aspect of it, if we're more likely to have a first pass success rate, that improves outcomes dramatically. Because what keeps happening if I miss the first one and I try again? What implications could that lead to for the patient?
Yeah, so there is data showing that for every missed intubation attempt, you're increasing the risk of mortality and morbidity for the patient in a non-linear fashion. So it's actually an exponential increase in risk for that patient. So definitely there's evidence showing that like increasing your first pass success is an important patient safety metric. And then um, if VL shows to be a robust way to improve that, then I think it's definitely worth investment as part of an airway kind of program, right?
Why does the risk go up for morbidity and mortality? Like what could happen?
Right. So that's where you have like more time with hypoxia, more time with hypercarbia, more risk of like critical hypotension events and things like that. Could your -1A outcomes start materializing with higher like numbers of attempts? Sorry.
What about the inflammatory response? Like if I just keep sticking in this laryngoscope, is that inducing trauma and
I
inflammation?
mean, if you're doing it appropriately, I don't think so. Like if you're trying to pass the tube through the airway and like the vocal cords a bunch, that obviously could increase the risk of trauma. Also, as paramedics start to panic because they're trying over and over and over again, they might use way more force. So that's actually a pretty good consideration there, right? Point.
That's a perfect bridge that I was going to ask you because, correct me if I'm wrong, I remember reading literature years ago that for every attempt you have, the likelihood of your success goes down because in your head, you're like, I'm already behind the 8 ball. I need to get this intubation. And if I don't, it's just going to keep rippling. So is there evidence to suggest that every attempt I do, it could increase the likelihood of subsequent failure?
Yeah, it's harder for us because we only really have 2 attempts, right, as per protocol. So, and there's a reason for that. If you're not going to get it on your second attempt, it's very unlikely that you'll get it on your third unless you're really planning on changing something in your approach, right? And that's why we want you to give the first shot your best shot because you only have one more after that. Um, yeah.
That's key because for your training and my training, thinking about like the human side again, let's say we weren't successful the first time. I think we need to have a deliberate approach and like, okay, this is what I did the first time. What am I going to do differently? Because we've all heard this old adage, like trying the same thing over and over again. It's the definition of insanity. So can you imagine
Mhm.
having that process in your head? It's like, this is what I did. I need to pivot and let's try a smaller blade. Let's try different positioning. Let's try a bougie now if we didn't use that. But like you said, we should do that the first time.
And you want to build a system around your procedures so that those kind of complications that may arise when you're just going with like, a tube with a stylet and your direct laryngoscope, you might find, oh, there's a bunch of soiling in the airway. I'll have to discontinue this attempt and suction, right? Well, for that, we teach that you should use the salad maneuver when you're doing intubation so that you have suction ready. Or, oh, look, like I have a grade 3 or super anterior. Well, you already have those things set up in your system so that you can get it and mitigate those issues on your first attempt, right? So you have your bougie if it's a grade 3, you have your partner ready to apply burp if you have a really anterior airway that you need to drop down into, right? So it's really about preparation and having the strategies ready to mitigate those factors right away.
What's a good mental model that paramedics could take away after listening to this to help prepare them? Like, is there acronyms or is it just so much practice you have to do to make sure it's kind of that framework's always in place when you approach these patients?
Yeah, so we really try to keep it very simple, right? So we just have a checklist that some of the services have integrated into their like intubation kits. And it just says, like, for the ones that have VL, use VL on your first attempt, use a bougie on your first attempt, have salad ready, and use your partner. And if you have kind of all those things ready and you've positioned your patient, which is actually one of the checklists, sorry, then you should be ready to mitigate kind of the common taxonomy of errors or complications that arise during.
For those that don't know, what's the salad technique?
Right. Sorry. So that's the suction assisted laryngoscopy and airway decontamination technique. We can maybe like overlay a video of it being performed if you want. And that's providing suction before, during, like the laryngoscopy attempt and during tube delivery as well. So it's a very visual thing. So hopefully we can get visual of it, but preferably performed with the Ducanto catheter. It's kind of designed by Ducanto, and he has a really good video like showing how to do it as well. But that really helps you mitigate those grossly soiled airways, and you never know when that's going to happen. So it's really just have it prepared on every intubation.
Why is that suction catheter more superior for soiled airways in comparison to the Yanker, let's say?
Right. So like the Anchor is not really designed for emergency airway management. It's very small bore. So it's not very good at like suctioning vomit or gross amounts of fluid or blood or anything like that. Canto and like the other ones that are of that design, like the Big Stick, which is the first more in Ontario, is more like big bore. And then what's really great about it is it's shaped like a laryngoscope, and you're supposed to hold it like underhand grip, so just like a laryngoscope. And that way it can follow the channel that you're creating with the laryngoscope. I can help kind of maneuver parts of the airway anatomy as well. So
It's more ergonomic. And
yeah,
correct me if I'm wrong, it should be placed just in front of the esophagus. So that's where the vomit's probably coming from, or if it's like esophageal varices. So subsequently, you can only pass through one hole, which is the trachea when you pass the intubation, right?
yeah, exactly. So kind of moving it to the opposite side of your intubation of your left hand, but it's staying in the esophagus, and then it'll continuously suction kind of whatever's coming out of the esophagus. Or if someone has like a skull fracture and they're bleeding down into their airway, that's usually where it's going to pull first, right? So you can keep suctioning there and keeping the larynx visible for your intubation.
We can see the barrier for that is the equipment standards don't specify services have to carry that. So of course it's all at the discretion of the service, but I've seen the videos and I will overlay the video. Like that's a good approach to a soiled airway.
Yeah, and it can be achieved with the Yonker. It's just a little bit less effective.
Out of sheer curiosity, have you seen first pass success rate go up when they've implemented the salad technique in the repo area? Or
We don't have data for that right now, unfortunately.
I assume
Anecdotally, there's a lot of tubes that I would have missed without using it so far.
so. If we look at that, does it actually get out like the soiled blood or from the vomit, like pretty dramatically in comparison to the Yonker?
Yes, absolutely. It is definitely more effective. And then the salad technique in general, it's a case where you would have maybe had to abort that intubation attempt to do more suctioning and then try your intubation attempt again. Whereas suctioning, aggressively throughout the intubation attempt made it so that it was a first pass success instead of, second pass success or failure.
And that could exacerbate the hypoxia. If I'm more time off ventilating and oxygenating and I'm suctioning out the air that is in their mouth and airway. So you can see how that could be beneficial.
Mm-hmm.
Let's linger on the anterior airway because we're looking at a QA project at CPC2 for first pass success rate. So I love that we're collaborating on this, but we're noticing from a sheer systems efficiency in the design of our documentation that people write interior airway and miss the tube. But what does that mean the airway is actually interior? And the second part to that is how can we correct it? Because you mentioned one way, but what does that mean an airway is interior?
Basically, all that means is that the airway is above whatever view the laryngoscopist is getting, right? They're going to say, I have an anterior airway because all I see is like esophagus or maybe just a little bit the bottom of like, the larynx or something, right? So one way that you can obviously mitigate that early is by positioning the patient appropriately. When you align all the axes of like the, auditory meatus to the sternal notch, that will help mitigate that because you're not like trying to lift their whole head in line. Also like the burp technique, does help kind of drop the airway down into view. And then obviously if you're not able to get, that grade 1 or grade 2, then having a bougie available will help you like still get first pass success on those airways.
I'd love to know your thoughts on this because I only have anecdotes, but the number one thing I see is the positioning is not ideal. So we don't align the axes because maybe we don't have the pillows. We're in the pre-hospital setting. Like I've asked for couch cushions. I've asked for clothes just to get in when, if you think about the OR, they have like mats that ramp people just to make sure it's aligned correctly. Do you think that's maybe the biggest barrier we're facing if we're not aligning the axes that leads to the interior airway?
Absolutely. Yeah. Yeah. Like this is the preparation aspect, right? Is the biggest thing. So, getting optimal position, and that goes for all your airway management, right? It might have been really difficult to bag because your patient wasn't positioned properly. Maybe you didn't get your SGA in properly or wasn't functioning properly because the patient wasn't positioned. So, as we escalate our care, that definitely needs to happen. Like proper airway or proper patient positioning, needs to happen for sure.
Have you looked at any of the data about mental preparation? Like, have you done this where you actually think about your attempt before you do it to help that execution and planning?
Yeah, so I actually haven't delved into the human factors data that much around like the skill or anything like that. I don't know what's available out there right now. Have you looked at it at all? Or
I've had some like brief data looking at it and just talking to other experts on this and just like human factors. They say like the mental preparation is actually so beneficial because it helps
Mhm.
calm you down. You have your plan devised. And it gives you that time just to think back and realize what you're going to do and what could potentially happen and how you could pivot. And I started doing this later on in my intubation career, and it did help. Then I did it with IVs, I did it with other procedures, and it just personally made me more relaxed. And I found I was more successful just already mentally preparing.
it's quite evident that when you go into a skill, it's saying, okay, well, if the airway is anterior, if there's a bunch of soiling in the airway, and like all these potential complications, if you think this is what I'm going to do to address all those problems, and I have the skills and I have the equipment and everything's good to go, then obviously you're actually more prepared and going to be a little more confident going into that skill, which makes a big difference. And then also, working through that game plan with your partner on the way to the call or just before doing the skill is also really good, right? It's like, okay, if the airways anterior, call for burp, and then they know what to do. So everything can be more efficient. Absolutely.
Do you think we need more cross training, like amongst primary care paramedics, advanced care paramedics, to address the silos approach? Like we can't do that anymore. And like, let's say like we're going to train with an intubation together. These are the expectations for everyone. And this is how we can maximize our success.
Absolutely. So we, went with the term of like intubation team, which is a primary care paramedic and advanced care paramedic working together. We absolutely do recommend that, ACPs train with their partners and that they have developed that shared mental model. The PCP can anticipate what's going to happen next and kind of own a part of that procedure.
That's incredible. For your research, did you look at pediatrics, adults too, or just adults?
Just adults right now. Obviously, pediatric airway is a pretty significant confounder because our first pass success with peds is so much lower to begin with. So we decided to isolate it to adults. Also, not every service that has VL has blades for the VL that goes down to the pediatric sizes. Like the most common one used is the McGrath Mac. Like they're available, but not every service has them.
What's the one downfall to video laryngoscope or downfalls, if there are any?
So there's a couple different challenges that have come up in the literature, especially associated with the different devices. But one of the most significant ones, which is why we're also advocating for the salad technique to be integrated into most intubations, is as soon as you get the camera completely contaminated, it's not a VL anymore. It's going to be a DL. So that's obviously a significant drawback. Although most of these devices can function as a DL as well because the geometry on the blade is not hyperangulated. So if your screen goes, just full of vomit, you can also just look DL. That'll be a good backup. Another issue is some of the video laryngoscopes have like a channeled blade. So then your tube is like preloaded into the blade. So you need to get like the exact view that would be congruent with that blade in order to pass the tube into the trachea or pass the vocal cords. So that's one complication that I've seen that's like given those devices a much lower first pass success rate than you'd expect. And then obviously there's the hyperangulated blades, which are pretty common, like in the literature. And that involved like an entirely different technique to passing the tube. Like you have to really like look around the corner. You're not like moving the structures around as much. And then one of the significant limitations, another one, is some Some of them don't work with bougies. So you need to get a bougie that's angulated enough to work with the video laryngoscope because they don't create kind of that straight path to the vocal cords. So that's been a complication that we've noticed with some services using like the Portec bougie, which is super straight with the McGrath VL, is that the bougie will just go straight into the esophagus because it's not following the blood.
Have you found there's any learning curves when switching from direct laryngoscopy to video laryngoscope? Because there is a different technique involved in it, correct?
Yeah, absolutely. So having, thorough upfront education on the VL with like multiple intubations on different mannequins, even like the peds, if you're going to go through that strategy, and then working with, the bougies and changing your bougie if you need to for it to work with your VL, all those things are definitely necessary if you're going to increase your first pass success rate. When I looked at some studies where they gave like almost no education to the paramedics before switching to VL, they actually decreased their first pass success rate.
What does the technique look like then for video laryngoscope?
I actually wouldn't, especially when you're using the standard geometry like McGrath Mac with like the 3 or 4. You're not going to really feel much of a difference when you're practicing it. The big difference is like you're not going to have to lift as hard, and you're not going to be creating like as much of a direct line of sight into the airway. So it's kind of the biggest adaptation. But honestly, paramedics catch this very quickly just by doing it a few times. So
I'm sure you've heard this, and my personal opinion is I agree that, especially with these tools, if we have them at our disposal, why would we not use the device that's empirically shown we could improve first pass success rate, such as using video laryngoscope and bougies? But like you said, one of the main complications that occur is you have a really soiled airway. There goes your view. Does that mean we should always train in video laryngoscopes if we have them and direct laryngoscopy? Because again, we cannot lose that old skill as well because we may have to use it one day.
I mean, so using the salad technique on every intubation is a really good way to mitigate the soiled airway problem. If we overlay that video, you'll see like this is like simulated blood. It's actually really tacky and like would completely occlude the camera. We didn't use the salad technique on those, and you're able to, clear the airway enough to use the VL pretty much every time. And there's actually data showing that this was done with residents, like learner physicians, when they practiced with VL, because it gives you a better understanding of the patient's like anatomy, better dexterity with the airway. The physicians that practice with VL had a higher first pass success with DL than the ones that only practice with DL. It'd be very reasonable to just continue using that and then become like an expert in your tool, which that's DL.
I like it too because the confirmation, because right now, if we're working together and I do an intubation and I say, the two pass the cords, that's only subjective and viewable for my eyes. But with the camera, everyone can see if they're in view, just saying you see it passing the cords there. And these are the subsequent confirmation methods. Because it may look like we're passing it, but that's why we have to always confirm with end tidal and as well as multiple different ways to prove we have it in the right spot.
Yeah, and I find with VL, because it's such a more like gentle technique, you're able to just maintain that view, pass your bougie, pass your tube over your bougie, inflate your cuff, hold the tube, pull the bougie out. You're still looking at the tube in the trachea that whole time. You can connect your BVM. You're still looking. Do your first few breaths while still looking, and then get your end tidal CO2, everything. And you have like continuous confirmation throughout your procedure, and you're like maintaining that position. So that's, I think, a really good upside as well with it.
Correct me if I'm wrong. Do some video laryngoscopes like record the view and the intubation attempt so you have that quality assurance piece and to say like the tube is passed at this time and here's the documentation to substantiate that?
Yeah. Don't quote me on this. I think the CMAC line of products have it, but I don't think the McGrath does, and the McGrath is the most common used VL in our area.
I'm just thinking, like, totally just thought came to me, and I want to know if you know it. Is there less like teeth trauma or oral trauma with video laryngoscope versus direct laryngoscopy in the paramedic world?
Yeah, unfortunately, I wouldn't be able to list off citations, but yes, there's less airway trauma and less esophageal intubations, which is really key as well. Especially like unrecognized esophageal intubations, which are a huge morbidity and mortality risk, right?
Which is catastrophic.
Absolutely.